Hello. Thank you, everyone. We were having some technical difficulties, but we are all good now. And thank you for joining us today. My name is Melanie Ernst, and I'm a regional director at Benefits by Design. Lindsay Gibson and I are pleased to be joined today by our speakers, Dr. Jonathan Gabor, Nicole Ardeel, and Dan Ekstrand, who will help us rethink obesity through discussing the science behind obesity, the stigma associated with it, how to start the conversation, and a modeling tool that shows healthy impacts that can be provided from adding in healthy measures. Before we get started, I have a few quick notes. First off, this webinar is being recorded and you will receive a follow-up email with a link to the recording afterwards. If you have any questions at all, please email us at info@bbd.ca. We'll also be running a Q&A at the end of the session, so please stick around. In the meantime, you can put all your questions in the GoToWebinar question interface and we'll do our best to address them at the end. And now to introduce our first speaker, Dr. Jonathan Gabor. Dr. Jonathan Gabor is a specialist in general internal medicine with postgraduate subspecialty training and expertise in several areas of cardiometabolic disease. He is board certified in obesity, a specialist in clinical hypertension, and a specialist in heart failure from the European Society of Cardiology. He continues to participate in knowledge dissemination and guideline development, serving on various subcommittees. Dr. Gabor is a representative of the Canadian NASH Network, a national collaboration of healthcare professionals with an interest in advocacy, education, and clinical research in non-alcoholic fatty liver disease. Lastly, he is also a member of the Scientific Committee of 2022 Canadian Cardiovascular Harmonized Guidelines Endeavour, with the mandate to harmonize and combine the numerous national guidelines, including those pertaining to obesity, hypertension, diabetes, dyslipidemia, and heart failure. So without further ado, let me welcome Dr. Jonathan Gabor.
Thank you very kindly, folks, and thank you also to the team for helping manage my slides. If you have any audio issues or anything, please let me know. Title of my talk, Rethink Obesity, Why It Should Matter for Employers and Benefits Providers. So again, the background is that I've been doing obesity for a number of years already, in addition to my work in the cardiac and metabolic realm. And the goal of this talk is really to help disseminate to a non-medical audience what's changed in the field of obesity in terms of outlook, in terms of treatment, in terms of approaches, and why this is of relevance to you folks out there in the audience in terms of benefits provisions, because actually there's been a lot of progress over the past even 15 years and even changes to our national guidelines as well. Next slide, please. So objectives, understand the latest guidelines regarding the science of obesity as a chronic neuroendocrine disease. And I promise not to hit everybody up with a bunch of medical, deep, heavy jargon, but really it does reflect the understanding and a change in the understanding of how obesity is perceived as not yet just another issue of willpower or of lifestyle habits, that there are actually fundamental neurological, neurochemical differences in the brains of folks who are living with obesity. And terminology notwithstanding, the word obesity still is used, but also words such as people with obesity or people living with obesity, again, in recognition, and we're trying to avoid stigmatization, in recognition of obesity, again, as a chronic lifetime to many degrees, a chronic lifetime condition. Review current treatments with demonstrated benefits in treating obesity and improving patient outcomes. So like other chronic conditions, there are many modes of therapy, including medication. Not that the so-called lifestyle habits of diet and exercise are out the window, but a recognition that this is only one pillar of therapy. And as I say to both lay audiences, patients, and to other physicians when I'm teaching them on obesity, I say, if losing weight, if it was all about eating less and moving more, we wouldn't have obesity. So obviously we do. So clearly it's not just a lifestyle-oriented approach. And lastly, develop awareness of an evidence-based library of tools to support employees, families impacted by obesity, because this is something that does impact everyone. Okay, so obesity, what is it? Now, there's a lot of ways to define it, but the common, current, contemporary, accepted statement is obesity is a prevalent, complex, progressive, and relapsing chronic disease characterized by abnormal or excess body fat, the medical term being adiposity, that impairs health. And that's really a very important distinction. It's not simply a number on a scale. It is recognized that folks who have obesity across different levels of body weight can have different impacts. Someone can weigh more and be less impacted from a cardiovascular or mechanical standpoint, and someone can have a bit more body weight on board and they're fine. They are truly fine. So this excess tissue has to actually somehow be damaging to a person, somehow impairing their health in some way. And again, complex, because it is complex. There's numerous inputs, numerous ways in which someone can become obese, in which obesity can be maintained, and again, numerous body organs, systems which can be affected by obesity. And just as a quick aside and a little bit of a plug, so it's still relatively new, the Canadian Adult Obesity Clinical Practice Guidelines were published in 2020, so not that long ago. And at the time they were published, they were actually the most downloaded article from the Canadian Medical Association Journal. So it had quite a splash, it made quite an impact, and it was the first time that the Canadian guidelines on this topic had been updated in 15 years. So it's very timely and was due for an update, and is markedly different than it was 15 years ago, and in fact has been recognized worldwide as being cutting edge, contemporary, and quite visionary, in fact, if I might say so. Next slide, please. And again, obesity has been recognized as a chronic disease. So both the CMA, Obesity Canada, which I'm proud to be a member, as well as the World Obesity Federation, you can see from the writing that there's a lot of similar wordings, similar emphasis, right? That again, this is a chronic condition, that it can come and go, it can relapse in the same way that any chronic condition has. There's ups and downs. You're not just obese or not obese, right? So again, a global as well as national recognition of the changes that have occurred. And next slide, please. So obesity remains one of the most prevalent chronic diseases in Canada. 27% of Canadian adults were identified as living with obesity is the term. And that's a couple of years old already, right? And what you can see, and again, you don't need to be a doctor or a cardiometabolic specialist to sort of get an understanding that obesity has wide impacts across many different body parts, many different other conditions, right? And that when you think about it in context, I mean, yes, there's obviously an overlay between having arthritis and obesity. It's heavy on the joints. There's a lot of overlay between having obesity and having high blood pressure, having diabetes, right, having heart disease. Obesity impacts all those things, but actually you can see that the prevalence of that is even greater than all these other chronic conditions. Right? So it is one of the most, if we're going to define it as a chronic disease, it's one of the most prevalent chronic diseases in Canada. And next slide, please. You should be looking now at the slide that says obesity, not simply a number, and that's really what this is. So obesity is, again, a complex disease in which, and this is how we define it medically, a complex disease in which abnormal or excess body fat impairs health. And some folks out in the audience might have heard of the so-called BMI, the body mass index, which is basically a division of a height over weight. And while it's valuable and still used, again, we know that it's not the end of the story, and it's not the only story. So yes, you can still classify obesity based on the BMI, but in terms, again, of a complication that someone with obesity can experience, BMI is not entirely and not meant to be accurate for that. We have other scales, other systems that allow us to determine, and that's not for the non-medical audience to know, but just so that you know that, yeah, BMI might categorize and classify obesity, but BMI doesn't tell us if someone's got heart disease or not. BMI doesn't tell us if someone's got arthritis or not, right? BMI doesn't tell us about someone's mental health, right? So all those things are not captured by the BMI. The BMI is clearly just a number. It's just an anthropometric measurement based on height versus weight, right, and the relative proportions thereof. We do still know, though, that BMI correlates with cardiac disease. That's true. But I can't look at someone, even me, I can't look at someone with a BMI of 30 and say, you've got heart disease. I can't make that determination, right? I can't make that determination to say you've got high blood pressure, you've got high cholesterol. So the BMI, stated to be outdated, still used for diagnosis and classification, and any folks who work in insurance, if you're looking at tables and measurements, you're probably going to come across a BMI. But we have other, in the business, in the field, we have other scales that allow us to more thoroughly determine how the obesity is impacting the patient's health. Next slide, complications associated with obesity. So again, obesity impacts the body in many ways, right? It's not simply, for lack of a better phrase, it's not simply dead weight that's sitting on the body, although that's bad enough, again, from a mechanical standpoint in terms of affecting the joints. I don't know if folks in the audience are familiar with a condition called sleep apnea. That's something that I treat very often, but there's a tremendous correlation between obesity and sleep apnea. The weight alone can press on the chest, press on the neck, and that can increase the likelihood of stopping to breathe while you sleep, and that's the condition known as obstructive sleep apnea. And that is challenging, again, for the patient, but that's also challenging as well from the standpoint of insurance providers. I deal a lot with folks who submit applications to insurance providers for coverage for sleep apnea machines, and obesity always plays into that. And I always tell the folks that losing weight will improve the sleep apnea. And there are folks who've been able to come off their machines if they lose weight and successfully maintain weight loss, or at least they don't require as much pressure on the machine, as much settings on that you turn the dial to get a higher level of air pressure to keep your airway open and keep you breathing at night. Mental health is something that never can be neglected when it comes to obesity. There's a tremendous interplay. Obesity can exacerbate mental health, and mental health can exacerbate obesity. Right? Blood pressure, diabetes, joint disease, high cholesterol, and heart disease, of course, something that is a big part of my practice as well. So all of these things are inextricably linked with obesity, and simply the management of obesity alone, the reduction in obesity alone, is enough to mitigate and improve these conditions. And I have a slide on that as well. I could talk to you guys about why people become obese. I can talk to you that for 3 hours straight, right, as to why people become obese. And yes, the environment matters, right? So obviously we live in an environment, and we have for some time, where it's very easy to access and overeat foods that aren't healthy, so to speak, foods that provide too much fat, too much sugar, too much salt, that taste delicious, let's be honest, right? And that are easy to consume, and the next thing you know, you've consumed way more than your body actually needs, right? So yes, the environment is something that's important, is never overlooked, but we are wired, we are designed to eat. We are designed to eat and to store energy. And the more we learn about this, the more we study this, the more we realize just how tightly controlled and how strong these systems are. You will have a drive to eat, and if you are obese, your drives to eat are actually different than those of someone who has never been obese. So there are fundamental neurological, biochemical differences between someone who is obese and someone who is not, right? So the reason I'm saying all this is simply to try to dispel the thought that has permeated even medicine at times, right? And certainly permeates modern common culture, that obesity is an issue of willpower, right? That someone who is lean has somehow better willpower than someone who's obese. That is decidedly false, and has been shown to be false, right? We're all slaves to our body chemicals, and obesity is no exception. And the human appetite system is designed to seek out food, to seek out pleasurable food, to get reward and benefit from pleasurable food. And those chemical signals and those chemical pathways are different in folks who are obese. So next slide, bias and stigma. So this is important, and move to the next slide as well, weight bias and obesity stigma. Weight bias exists everywhere, right? We have it. We don't know that we have it, right? I'm not trying to blame ourselves, but we all have it. Doctors have it, and obese patients have it. They've internalized it, right? So this is a negative attitude, a subconscious attitude and a view regarding obesity and towards people who are obese, which, and I'm not saying we're bad people, right? It's inadvertent. It's subconscious, the issue of weight discrimination. And these lead to barriers in the workplace, right? This has been documented as such. Negative stereotypes, lower hiring success, lower starting salaries, as well as fewer promotions and opportunities. The implicit, and I use that word carefully, the implicit assumption is that someone who is overweight somehow is, again, not as hard of a worker, again, poor willpower. It probably comes from a perception of having poor willpower, not as intelligent, not as successful, and not as capable. Because think about it, if you have that implicit bias, again, not because you're a bad person, but just because, right? If you have the implicit bias that someone can't lose weight because they don't have willpower, well, how are they supposed to do their job well, right? So it's unfortunate, and again, it's not about blaming other people. It's just unfortunately something that exists in us. The way around that, the way to manage that, the way to deal with that, and the way to overcome that is to just be aware of it and to just check it, right? And to just, again, be conscious and aware of it. Next slide, please. The prevalence of weight bias. So I'm not trying to put myself on a pedestal, right? Weight bias can come from healthcare providers, right? And it's funny, and I don't mean ha-ha funny, but even overweight healthcare providers can have weight bias against overweight patients, right? It's that pervasive, right? So people with obesity have experienced weight bias from a healthcare provider. At least 50-50 of adults with obesity have been stigmatized by coworkers. I know I have when I weighed more, and I work in healthcare, right? And kids too, right? We all know that, right? Anybody who's been obese as a child knows that, right? That they've received bullying or other negative interactions as a result of being obese. So the issue is not just all of this, although that's all very important, but the issue is also that it actually being subject to weight bias, being subjected to weight stigma, actually damages the journey of a person with obesity in terms of losing weight. So people subjected to weight bias actually have a tougher time losing weight. They actually have worse outcomes. So it actually impairs their ability to lose weight, right? Probably through a number of ways. Again, mental health, giving up on treatment strategies, not seeking out treatment strategies, not seeking out the right providers, because they feel, what's the point, right? So it's not just bad for a person's image, it's not just bad for a person's psyche, it's actually bad for a person's health. Okay, so next slide, again, internalized weight bias. So this is a patient believing that their obesity is their fault, and this is huge in folks who deal with obesity, right? They've tried this, they've tried that, they've tried diet A, diet B, Dr. A to Dr. Z, internet, dietitians, what have you, and it's failed. So eventually they believe it's their fault. When in fact, again, as I've alluded to, and I'll talk more about it, that this is really a chemical problem, right? This is a neurological, hormonal, biochemical difference that is being expressed in an obese person that is different than someone who has never been obese. We've all eaten more than we needed to. We haven't all become obese, right? So we've all had cravings for food, and we all haven't become obese. So there is something different in an obese person. Next slide, please. Living with obesity is, again, challenging due to personal and societal pressures, right? So again, this is about really challenging assumptions and really understanding that there's been a lot of research that has come out that has demonstrated what obesity actually is and how to treat it. Okay, so next slide, it should say the real facts are. So again, about different from different people, but about 70% heritable. And again, these are neurological neuronal processes. So everybody's got a system of appetite. We're all designed that way. We're all Homo sapiens, right? So we were evolved in a calorie scarce environment, right? And our bodies will very, very, not just progressively, but very vigorously defend against fat loss. Evolution never cared what we look like in the mirror. It just cared about getting through to the next day and procreating, right? So can't procreate if you starve to death, right? And once you're finished procreating, I guess technically evolution doesn't care if you die. But again, this is how we developed as human beings, as biological systems. So there are actually 3 layers to appetite. One is simply the body detecting a caloric deficit and saying, we're short of calories here, let's eat, right? Nothing else, no more, no less, right? The second layer is, again, we're all human beings. The second layer is what they call the hedonic pathway. It is something that is pleasurable. So it's the pleasure we derive from having food, right? Again, we're all human beings. Let's be honest, right? Food tastes good and food feels good, right? So we evolved that to be able to reward ourselves, to be able to develop a reward stimulus from eating, right? So it's not just robotic, I'm hungry, I will eat something. It's the reinforcement of feeling good from eating something. So that's level 2. And level 3 is what we call the executive control, which is technically willpower, if you want to call it that, but it's basically more than that. It's the control that we can consciously exert over our food, right? Over our food choices, right? You can imagine that when you've got 2 primitive, very evolutionarily created systems up against one more higher level function, you can imagine which one will win, right? The subconscious will always win out over the conscious, right? And so that's why technically what we perceive as others, we perceive a failure of willpower, but it's not that, right? It's merely the other systems exerting their dominance, right? And again, there are true structural and chemical differences between folks who have obesity and folks who don't, right? I don't have a slide on it here, but when I present to physicians or other healthcare providers, I like to put up a slide of an MRI image and images that show folks who are obese that after they've eaten a filling meal, their brains are still registering as hungry. The centers of the brain that control the appetite are still registering. They're off the charts. They're still registering as hungry, right? Which parallels the experience and mirrors and illustrates the experience of people with obesity who say that I'm hungry after I eat. I can't stop eating, right? Their brain is saying you're hungry, eat, right? And again, the body will progressively and very vigorously defend against fat loss. I'm not saying you have to count every calorie. I'm just saying that the body is aware of every calorie and will detect even small amounts of caloric deficit and will do whatever it can to not lose weight, right? It needs that fat to stay alive, or that's what it's thinking, right? I don't know if folks, depending on your age in the audience, but if folks remember the TV show The Biggest Loser, they all gained the weight back. They all gained the weight back and their metabolisms fell through the floor. So it became harder for them to lose weight afterwards because their metabolic rates plummeted. And that's something we see in a lot of obese patients. So it's really a vicious cycle. And in some cases, I wouldn't say trying to be negative and say set up to fail, but again, it's fighting against evolution. Okay, so next slide, messages to combat bias. So again, this is a real condition. It lives in the brain. It is influenced by the environment, but again, it's progressive and the body really, really tries hard to not lose weight. And again, past weight loss efforts fail. There is such a thing as a yo-yo. That is a very, very true thing, right? But again, because the same chemical pathways in the brain are saying eat, 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 and on top of that, the metabolism plummets, right? So I'm not trying to be negative. Let's talk about things that do work, because treatment does exist for this condition. And again, it's both behavioral, and there is medication, and there is, of course, bariatric surgery. So next slide, please, the treatment of obesity. And next slide after that, obesity can be treated. The 3 pillars of obesity treatment are, so yes, we still focus on behavioral interventions, lifestyle interventions, but what we recognize is this is only one aspect of it. So of course, people have to watch their caloric intake. Of course, people have to be physically active, but it's impossible to burn off when you're, and again, I know this as both a patient and a provider, right? It's impossible to burn off dozens of kilograms of fat, right? It just doesn't work that way, right? So telling an obese person to just eat less and move more, that you can imagine in retrospect that really was never going to be successful, right? The goal of exercise in obesity isn't really just to rev up the metabolic rate. It's for cardiovascular benefit. It's for some amount of energy burn and some amount of fat loss, but it's for overall health improvement. Again, cardiovascular benefit, musculoskeletal benefit, keeping in mind that a lot of folks with obesity physically find it hard to move, right? So, if they haven't exercised for a long time, or if their joints are bothering them, you can't tell someone like that to just go hit the gym and that's that, right? So it has to be realistic and it has to be well thought out, right? So again, diet and exercise are only one pillar. Bariatric surgery does work. It causes tremendous amounts of weight loss, a lot of which can be maintained, but there can be a wait time and there has to be a very careful selection process for someone with obesity. Let me move on to medications. And I have to say, when I first finished medical school and training and got into the field, I didn't know much about obesity medications, and I was already moving into the cardiology realm. But again, when you think back retrospectively, you use a medication to treat other conditions. Why not use a medication to treat obesity? And it's not the old school weird stuff off the internet, crazy stimulants that are damaging to someone, right? There are 3 medications that are approved in Canada. They each do different things, and they are not odd in any way. They have true medical uses. Contrave, naltrexone, and bupropion works on the hedonic part of the brain to help control cravings. Orlistat is not commonly used anymore. Some people in the audience may be familiar with it. It's the fat blocker. So you can imagine that has side effects. People don't really like, pardon my language, but people don't really like pooing out fat, because that's exactly what happens. It doesn't allow the intestine to absorb fat. So you can imagine there isn't a lot of uptake of that medication or a lot of tolerance of that medication. And then you've got Saxenda, liraglutide, which, again, I'm not trying to do a whole medical talk to a non-medical audience, but really the way it works is, again, it used to be used for diabetics and still is used for diabetics, but the way it works for weight management is it literally addresses those components of the brain chemistry that I was referring to. So it literally helps regulate appetite by, in essence, telling the brain that it's full, right? Shutting off or controlling or interrupting that loop where your brain is saying, I'm hungry, I'm hungry, I'm hungry. People have lost good amounts of weight on this medication. It's a medication I prescribe, that and one other of its newer cousins, that really allows folks a significant degree of freedom, right? And that's actually the word they use. I'm not trying to overstate it. They don't get those feelings anymore that they're constantly hungry. They find that they're able to eat portions that, for lack of a better phrase, everybody else does, right? So they eat something, they eat a normal sized meal, and they feel full, and they remain feeling full. For some folks, they say that's the first time in their life they've ever felt that way, right? So it's actually remarkable. Next slide, please. We're nearly done. Potential benefits of 5 to 10% weight loss. So this is very important, and this is something that I tell folks all the time, is that this is not about losing 50% of your body weight. This is not about how you would look on a magazine cover, or this is not about some unrealistic, unattainable goal. That purely from a health standpoint, the benefits of weight loss begin to accrue with relatively, what we would think is relatively modest amounts of weight loss. So all you need to do is shed 5 to 10% of your body weight and maintain that, and all of these good things start to happen. A reduction in blood pressure, reduction in diabetes, improvement in quality of life, improvement in joint pain, improvement in breathing, right? So obviously if you lose more, fine, it's good, but doesn't have to be the goal to shed tons and tons of weight. Next slide, please. Improvement in obesity-related complications. So again, this is the same idea. Again, I treat a lot of these conditions, if not all of them. I don't do a lot of ovarian stuff as a cardiologist, but even fatty liver, a reflux is what we call gastric reflux, so heartburn, basically. All these things improve with amounts of weight loss that, again, you would not think would be enough to do the job, but you're darn well right, they actually do. Next slide, please. The economics of obesity. So again, you probably don't need a doctor to tell you this, but there's a tremendous burden of obesity. Again, it's both direct and indirect. So obviously more hospitalizations, more healthcare utilizations, more visits to the ER, more visits to doctors, right? And again, the stuff that obviously would more matter to you folks, the indirect costs, disability, lost productivity due to illness or even early death, right? Next slide, please. Conditions associated with obesity. So there is a substantial cost, right? So across all of these things and then some, right? So truly, if we can manage the obesity, we would hope to not have to throw all our resources at all of these other things too, or that it would be easier and less costly to manage all of these other things. Again, I do all of these topics in my practice, and I can tell you that it's just easier when someone weighs less. I'm just being honest, right? So a type 2 diabetic doesn't need as much meds. A hypertensive patient doesn't need as much meds, or their blood pressures are better, right? I don't need to send people with heart disease for as many bypasses or stents or whatever, or they're less likely to have a heart attack, right? So all of these things matter. Next slide, please. Obesity associated with increased absenteeism and presenteeism. So again, this is something that you folks are more familiar with than me, but I see it in my practice as well. So again, if we're able to manage this somehow, or manage this better, the hope and the goal is to get these things taken care of as well. And last slide, or last couple of slides, improving access to obesity care. So I'm not here to tell you exactly how to set up your programs and everything, but obviously it's something more to talk about in the question and answer session. And there's nothing wrong with wellness programs, but again, I just wanted to bring that out there, that really this is not again, I know I'm driving it home, but not an issue of willpower, not an issue of failure, right? And not just an issue of eating less and moving more. There's nothing wrong with a gym membership. I shouldn't say that during COVID, but whatever. There's nothing wrong with a gym membership. There's nothing wrong with dietitians. Of course, all those things are very helpful, right? But we know that alone has not done the job. And it's not a failure of the system. It's not a failure of a person. It's just, now that we understand biochemistry better, now that we understand the field better, that we know that that's not sufficient in and of itself for the vast majority of folks. And next slide, what can be done to support employees? So create an environment where employees with obesity can feel comfortable. Training on respectfully speaking about obesity. Folks can be sensitive. I'm not just saying that to be insulting. I mean that. The sensitivity comes from a place of past stigmatization, past misunderstanding. So that's where it's coming from, right? It's not just out of nowhere. Encourage employees living with obesity to seek proper treatment, and again, offer access to proven therapies. It is a multimodal approach, including cognitive behavioral therapy and including anti-obesity medications. And so in summary, last slide, summary, obesity is a chronic disease. Current employee benefits packages might not provide access to proven treatment options. And again, to provide a recommendation from me to provide or direct your employees towards weight management resources, which again can include information about treatment options that we know do make a meaningful difference. Because again, it's not about dropping 50% of your body weight and then gaining it all back. It's about making more modest differences, but at least those that are sustainable and long-term, because that actually has a health outcome. And take questions later, I guess, but thank you very kindly for your time.
Perfect. Thank you very much. Now to introduce our next speaker, Nicole Ardeal. Nicole graduated from the University of Victoria in 1996 with a double major in English and creative writing. She then inadvertently and auspiciously found herself in the insurance industry in 1997 as an employee benefits specialist with one of the major insurance carriers. 5 years later, she started her own insurance practice and began to specialize in employee benefits. Nicole's goal is to provide meaningful, sustainable, and fairly priced plans to local business owners. She believes strongly in employee education and engagement. She also has a passion for the mental health and well-being for not only herself, but everyone around her. She knows you must walk the walk and talk the talk in order to achieve authenticity. Throughout her 25-year career, Nicole has supported hundreds of Vancouver Island business owners and thousands of local employees. Nicole is also a proud member of Greater Victoria Chamber of Commerce, Think Local Victoria, Advocates, and the Canadian Group Insurance Brokers CGIB Association. With that said, please welcome Nicole Ardeal.
Thank you very much, Melanie. And thank you so much, BBD, for the opportunity to speak today. Good day to all of you, and thank you for attending this session. I am honored to be asked to speak today, especially among my esteemed peers. So in the last 30 minutes, you heard a lot about the science behind obesity and how to reposition your traditional mental model surrounding obesity. In the next 10 minutes or so, you'll learn some considerations about what you can do with this new knowledge. So first, some background. As per my bio, I've been in the insurance industry and specifically the employee benefits sector for many years. And even as far back as the late 90s when I started, I remember being irked by the term lifestyle drugs. So for those of you who may not know, this is the unofficial term given by insurance carriers to a grouping of drugs that, by definition, include drugs to support a manner of living. A quick Google search cites a paper from 2000 that describes lifestyle drugs are drugs used for non-health problems or for conditions that lie at the boundary between a health need and a lifestyle wish. Now, although this quote is 20 plus years old, I can attest that the term still exists in the insurance vernacular. Anti-obesity medication is typically included in this classification, along with drugs for fertility, erectile dysfunction, and smoking cessation. It is possible that lifestyle drugs have not been included on the extended healthcare plans that you look after, unless there was a deliberate decision to include them. And because of this typical non-inclusion, lifestyle drugs are often not a subject that is brought up or discussed. So fast forward 20 years. I was attending a national drug forum back in December. It was literally my 70th webinar of 2020. Lindsay, I think you're ahead by one slide, just so you know. Thank you. It was literally my 70th webinar of 2020, and I was doing what probably some of you have also done during all of these webinars, and that is multitasking while half listening to the speakers. The presentation in question was also in regard to obesity, and I remember hearing the term lifestyle drugs. My ears pricked up and I stopped whatever distracting thing that I was doing, and I shifted my full attention to the presentation. It was a pivotal moment for me. It finally hit me how wrong this term is. Weight is not a behavior, and obesity is not a lifestyle choice. This presentation was a catalyst for me to get moving toward change. So since last December, I've done a deep dive on the research and uncovered a library of evidence-based resources. I've also found an excess amount of misinformation and bias. It became clear that we must make a shift. Now, as per my bio, I've been a champion of supporting mental health for many years now, and I've been working hard to reduce stigma surrounding this very important topic. And in the last 19 months, I have seen the collective work and support of so many Canadians gain momentum as we turn the tide on talking openly about mental health conditions. Those of us who have been at the forefront of this wave finally feel validated. Next slide, please, Lindsay. And now that Oprah and Prince Harry and Ted Lasso have joined the conversation on their various Apple TV shows, I feel we can shift our focus to another area that needs our attention. The framework to reduce stigma surrounding obesity is already there, developed by many years of reducing stigma around mental health conditions. We simply must become more educated around this topic and work on our understanding that obesity, as per Dr. Gabor's emphasis, is a complex chronic disease. And like many other chronic diseases, the impact goes far beyond the personal and private health of any individual Canadian. The cost on our healthcare system and the cost to business is enormous. We can no longer ignore the impact. So my first question is, why aren't we talking about this? In my opinion, it's fear. Lindsay, next slide, please. Another Google search tells me that fear of snakes are at the top of the list for Canadians. And that may be true, but a fear that does not show up on this list, which I think by its nature has been omitted on purpose, is the fear of addressing uncomfortable topics. Now, all of you here are in the insurance industry. Next slide, please, Lindsay. And I hope I'm not the first to break it to you, but when you entered the insurance industry, you ticked the terms and conditions box that agreed to addressing uncomfortable topics. It is important to note, as Dr. Gabor mentioned, this is not simply a crusade to lose weight. Obesity is a chronic condition where excess fat, body fat, impairs health. Dr. Gabor's already talked about the BMI, which we know is a criticized tool to measure body fat composition, and what it does not measure is health. Next slide, please, Lindsay. A high BMI doesn't necessarily mean a person is unhealthy, just the same as a low BMI doesn't mean a person is healthy. I'm sure we all know many people who look great on the outside, but are a complete wreck on the inside. The key is to measure how weight impairs health and creates other concerns and conditions. Our focus should be on exploring and finding the healthy weight, not an ideal BMI. So that brings us to the second question. How is this applicable to you, to your business, and the organizations that you work with? In my opinion, the answer is threefold. So here, friends, is your call to action. Next slide. First and foremost, reduce your own bias. Listen to the science and read the research. Acknowledge that obesity is a complex chronic disease. Next slide. Understand that obesity has a cost to the organizations that you work with. So agree that addressing this issue with employers and plan administrators is a priority. Use an evidence-based obesity modeling tool like the one Dan is going to talk about next to understand and communicate this cost. A specific modeling tool based on the demographics of your client will show the numbers. The cost of meds for high blood pressure, susceptibility to depression, CPAP machines due to sleep apnea, lost productivity due to absenteeism, short-term disability claims. Just like any other chronic disease, there are increased costs associated with obesity. I have personally used this tool that Dan is going to demonstrate in approaching and starting the conversation with several clients in the last year. For example, 120 life group, the numbers spoke for themselves. Over the next 5 years, the tool predicted that obesity would cost $1.8 million. Divided by 120 employees, very simple math, that's an average cost of $15,000. This tool introduced a concern that my client didn't know they had to pay attention to. And the result? We added evidence-based anti-obesity medication to the plan, and we shared communication material that HR could distribute to the employees. Next slide. Finally, reduce stigma and remove the barriers. Talk to your insurance carriers and add evidence-based anti-obesity medications to the list of covered drugs. Also, ensure they are not called lifestyle drugs. Request a high enough maximum so the medication cost will not be a barrier for the employees. For the client I just referred to, I presented the amendment as adding healthy body drug classification instead of using lifestyle drugs. I suggested this to the insurance carrier that we use this name, got the thumbs up, and that's the term we're using. Encourage HR to create a communication plan to help normalize obesity in the workplace. There are so many tools available, as Dr. Gabor alluded to, newsletters, posters, videos, webinars. Encourage your organizations to promote their employee and family assistance program, use CBT, cognitive behavioral therapy, to talk specifically about weight, obesity, and all the feelings that they likely associate with this condition. And encourage plan administrators to recruit ambassadors from within to help promote the support. Finally, start the discussion. Learn how to talk about obesity with your clients and partners. Even if that means sensitivity training around the words. Learn to be open and non-judgmental. Be tactful, but don't be shy. Again, change the language from obese person to a person who lives with obesity. Steer away from the unhelpful and disrespectful solutions, such as eat less and move more. Next slide, please, Lindsay. You would not tell a person living with depression to cheer up, or a person living with asthma to breathe deeper. Therefore, telling a person who is obese, who lives with obesity, to eat less and move more is not helpful, practical, or useful. So as you can see, I am passionate about this subject. But grasping hold of the topic of obesity has not been without my own relearning, trepidation, and unease. I have had to evaluate my own implicit bias around weight and obesity. Certainly, these conversations can and will be uncomfortable and awkward. But what is the alternative? Just because something is uncomfortable doesn't mean we can't or we won't or we shouldn't talk about it. We are in a world where important things are discussed, and this is one of them. As a benefits advisor with a passion for change, I feel that it is my duty and obligation to lead my clients, partners, and colleagues to places they might not have known to explore. Next slide, Lindsay. I believe we are in a unique position where we can inspire, teach, and above all, help. In this ever-evolving world of leading people, we need to continue to embrace the spirit of inclusion and show our compassion and support for those that need it. And we want to do that by letting them know first and foremost that we want to have that conversation and that we want to help. Thank you.
Wonderful. Thanks, Nicole, very much. Now to introduce our final speaker, Dan Ekstrand. Mr. Ekstrand has been involved in the innovative pharmaceutical industry for over 20 years. During that time, he has assumed numerous roles, including sales in both GP and specialty care, field training, district management, key account management, and marketing. Dan first joined Novo Nordisk in 2010 and is currently accountable for patient access in the public and private payer markets. In addition to his professional accountabilities, Mr. Ekstrand feels a sense of responsibility to improve the care and outcomes for all individuals impacted by diabetes because he has several immediate family members living with this condition. As a result, he is very passionate about Novo Nordisk's global commitment to defeat diabetes and understands this bold mandate is only possible by addressing obesity and aligning with like-minded public philanthropic partners. Please join me in welcoming Dan Ekstrand.
And thank you so much for the opportunity. I really want to reprioritize the conversations with Dr. Gabor as well as Nicole are really the critical ones. And I want to make sure that the audience has an opportunity to ask any questions they may have. But thank you for giving me the chance here to present a little bit about Novo Nordisk and some of the resources that we've put together to help you through that journey. So as mentioned, we do have a very broad mandate where we're trying to defeat the conditions that we treat. And we realize wholeheartedly that we cannot begin to defeat diabetes if we don't have significant and meaningful impact when it comes to obesity wellness. We know that obesity contributes roughly 40% of the burden of diabetes. So this is a large mandate for us. It's a bold, audacious goal that we do have, but it's one where we really feel that we can make impact. And we know that we need to have public-private partnerships and other individuals involved to help accomplish that objective. So we were having a lot of really engaging conversations with benefit advisors like yourself, as well as employers, and there were many that were energized and wanting to do something within this space, but they didn't know where to go. And part of our complication and challenge was that we had a lot of conceptual conversations, but we didn't have anything of substance with which to share. So we went down a journey of trying to create some tools that might be relevant to you in having that engagement and bringing up these conversations with employers. And we started really threefold. We had first one bucket around understanding the impact of obesity within a workplace. That's around employer education. There's the obesity modeling tool that was referenced by Nicole, and I know she's used to good effect. I'll go through that in a little bit greater detail later on. We have webinars from specialists such as Dr. Gabor that are certified within obesity, and that is a fairly clear distinction, but they'll provide information much like Dr. Gabor did around the complexities and why obesity is a chronic condition. We also have PowerPoint presentations that can be delivered to the executive team or the HR team, and this is appropriate for the benefit advisor audience. The second bucket that we took a look at is how do you begin to implement an evidence-based obesity wellness program? So part of that was around what does a benefit plan look like? How do you design something that's holistic in nature and supported by the clinical practice guidelines referenced by Dr. Gabor? So again, we know that diet and exercise are part of that equation, as are psychological services, as are evidence-based anti-obesity medications. So those all fall into the umbrella, and there's some guidance there around how you can make it into structure a benefits plan. There's employee questionnaires, and there's also some guidance around how do you engage on this subject. We talked about mental health, and I, being long in the tooth, recall days where we didn't really bring up mental health. It too had stigmas and biases and still does to this day. And obesity is no different. How do you respectfully bring up these conversations in an appropriate environment in an appropriate manner. So there's some guidance to be had there. Finally, we wanted to make sure there were some tools available for employers and their members. And so we have a series of newsletters. All these newsletters are agnostic, evidence-based, and supported by clinical practice guidelines. There's 10 in this particular series, and they run sequentially. There are people with lived experience. There's videos, and I think anyone that lives with obesity or knows someone that lives with obesity can certainly relate to these videos. And then we also have some other tools that come into play around how do you begin that process and how can you live a more filling and healthy lifestyle. So those all become part of the process. And wanted to make sure that these are available to you. If you want to learn more details, I'm happy to have that dialogue and conversation with you. All these tools are available as is. You can simply duplicate them, you can customize, you can modify, you can take pieces and elements. So it's almost like a resource library that is turnkey. We did have some insurers, as an example, Desjardins Insurance recently removed language from their standard contract that now allows for anti-obesity medications to be part of their standard offering. And they took the materials and simply changed their color palette. So we're trying to be flexible here in terms of what might be appropriate and helpful. The one tool that I really wanted to do a bit more of a dive on is the obesity modeling tool, which was referenced by Nicole. And I want to sort of provide a little bit of context around this. I think first and foremost, this cannot be the sole tool. I think you need to have the passion and commitment to try to make a change and understand this is the right thing to do for employers and their employees. But this can offer a bit of a supplementary support system. And while I don't want this to be a financial conversation exclusively, this could present some of the dollars and cents that are associated with the comorbidities associated with obesity. It's relatively easy and turnkey. It's available online. I think you'll be provided a link as well as a password, and there'll be follow-up communication around this. But essentially, you just enter a few different variables. We want to take a look at demographics, so you can truly customize it to the customer that you're speaking to. You enter details such as number of employees, average salary, salary increases, gender breakdown, as well as the ages. If you don't put any of that information in, it'll simply default to Statistics Canada. And you also put a timeline around what you want to see for the progression. The 5-year timeline for me sort of represents the best of modeling. And then it'll give a specific breakdown around the comorbidities. This tool really did need to have rigor and integrity behind the data. So we know there's a whole host of comorbidities that are associated with obesity. Dr. Gabor went through most of them. We only included those that had the strongest of evidence. And so there were some elements. This is not an all-inclusive offering. It is a very conservative estimate. We know, for instance, that with joint health, hip and knee replacement, that there's a very strong correlation and linkage, but the data actually wasn't strong enough, so we didn't include that in the modeling itself. We also know that employee engagement, while these are softer qualitative measures, we do know someone that's been helped to find their healthy weight and embarked on that obesity wellness process, if their employers were part of that engagement, we do feel that they likely will have higher job satisfaction and higher loyalty. But again, these are conceptual nature. You don't need to squint too hard to suggest that that likely would happen, but the data integrity wasn't there, so it wasn't included. The model's very robust. It is 30 pages of assumptions and references. So I think you can get a fairly clear-cut example of what this means for that particular employer or your particular client. And the comorbidities that really that we did take a look at, there were 5 where the data met our standards. That was around diabetes, cardiovascular disease, mental health, cancer, and sleep disorders. When you plug those variables in, and this takes about 5 minutes, you will get a breakdown of the number of employees that are impacted by those comorbidities and the changes after therapy has been added into the mix. You'll also get a breakdown in terms of costs. So the costs associated with type 2 diabetes that is directly attributable to obesity, before and after snapshot. A couple important distinctions around that. All the variables that we have are exclusively and directly related to obesity. So the cost of diabetes, as an example, can be quite large. We just carved out the cost of diabetes that was directly attributable to obesity. And the one other element that comes into play is we only included those costs that are being borne by the employer. So for instance, if someone has cardiovascular disease that is attributed to their obesity and they have a heart attack or they have a stroke and they're hospitalized, we know there's significant costs to the system. They are hospitalizations, they have rehab and the like. Those costs are actually removed from the modeling. So it's exclusively the cost associated with obesity and those comorbidities and the cost attributable to that particular employer or private market. So we really carved it out. I think it's an invaluable tool that can help initiate the conversation. But first and foremost, I think it really needs to be part of a broader objective, and that is to make a change, to be that catalyst for change. I think you had a sense of that with Nicole. She probably doesn't give herself justice, but I suspect when she went in front of that 120 employee organization, she probably had them at hello, and it was based upon her energy and her commitment to have those challenging conversations, but appropriate conversations, and her commitment to affect change. So I'm going to pause there because, again, I really want you to have opportunity to pose any queries you may have to Nicole and Dr. Gabor. But do know, if you want to have a bit of a deeper dive around some of the tools that we have created and how they can be utilized, I'm happy to do so. Simply filter those through Lindsay, and I'll set aside time to go through it in greater detail as you see fit. Thank you.
Wonderful. Thank you so much, Dan. So that concludes our presentations for now, and we'll now transition over to the Q&A. We will be respectful with time as we are running over. So I will actually hand it over to Lindsay Gibson to go through the submitted questions.
Thanks, Mel. So the first question here is, will there be CE credits available for this session? And the answer is yes. They're just pending final approval from each of the provinces. The next question is, and this one's for Dr. Gabor. With the example of the MRI slide of the brain you mentioned, is that neurological disconnect primarily due to leptin resistance, or are there other neurological factors that contribute?
No, very good question. Leptin's actually only part of the story. There's just offhand, there's probably a bunch of others, maybe a half dozen other ones, other brain chemicals that are involved as well. So it's actually not, in that particular study, it wasn't actually the leptin specifically. It literally was the activity, the heightened activity of those brain cells that were lighting up saying, give me more food. It was almost as if the person hadn't eaten, right? Even though the person was essentially satiated, they in this particular case they had felt full, and they had perceived that they had eaten what would be considered a routine meal, but the brain cells themselves were hyperactive, sending out signals saying, feed me, right? I mean, that's I wouldn't say an extreme example, but that's more of an illustrative example. Again, it mirrors the experience that a lot of folks with obesity have had, where they just, again, it's not always about craving or binging, although that is part of it at times. It's just that perception the perception of looking at food differently than someone who has never been obese, right? The just feeling of wanting food more often than another person would, right? Again, what I hear about it anecdotally and narratively when patients are speaking to me is that, again, they say that, and again, without trying to push the medication aspect of it, but it works to say that they can tell the difference. They say that before medication, I felt like I was always hungry. I felt that the minute the food had left my stomach, I was ready to eat again. Right? Whereas now they say, look, I eat lunch and then I'm good until dinner, and maybe I'm not even that hungry at dinner. Or, you know, I eat breakfast and instead of by 9:30, I'm ready to eat again. And if there's snacks in the coffee room, whatever, I'll be grabbing that. They either have a normal sized lunch or they skip lunch entirely. So again, it's not about intermittent fasting or anything like that. I know that's a whole separate category, but it literally is about reducing caloric intake, because that actually does help, right? About having the ability to reduce caloric intake without being driven to eat by forces beyond your control.
Great, thank you, Dr. Gabor. There's another question for you. What is the average wait time for an individual to see an obesity specialist in Canada?
Amazing question, quite variable. It depends on the availability of those folks. A lot of us in the obesity field, there's no Canadian, even though the Canadians are very cutting edge and very well ahead in terms of the knowledge in the field, there's no Canadian certification for obesity. A lot of us most of us, almost all of us, are certified by the American Board of Obesity Medicine. So we take U.S. training and write a U.S. exam to be able to call ourselves a diplomat of the American Board of Obesity Medicine, ABOM as we call it. So ABOMs are becoming more common. They were quite rare, but ABOMs are becoming more common. There's at least a few in every major city in Canada. There's a lot, I think a lot of folks here are on the line, might be from Ontario. There's a lot, no, there's a good number of them in Ontario. One of our main national heroes in the field, Dr. Sean Wharton, who was the first author on the Canadian Obesity Guidelines. I think he's based out of Hamilton. He's an internist by training like myself, and I don't think there's a tremendously long, I mean, he's busy, but I mean, I don't think you see him next week, but you certainly don't see him in a year. Vancouver, Calgary, I think you could be looking at a few months. Here in Manitoba, myself and a few others participate in obesity medicine, and this is a totally broad thing to say, and please don't quote me widely on this. Usually I can see people, you know, about a month or two, right? Even if the initial visit is a hi, how are you? Thank you for your file, and let's get started. And then subsequent visits are more thorough after that. At least the initial review by a physician can be, I figure 30 to 60 days, but it can be quite variable.
Great, thank you. There's one last question, and it says, does BBD have any reporting on lifestyle drug anti-obesity inclusion on plan and reduction on disability claims? I don't know the answer to that, but I will find out and get back to you after this session. And that's all the questions, Mel.
Great, thanks, Lindsay. I'd like to say a big thank you to Dr. Jonathan Gabor, Nicole Ardeel, and Dan Extran for sharing insights on rethinking obesity. A quick reminder before we part ways that this webinar has been recorded, and the recording link will be emailed to you at the end of the session. You will also receive a follow-up survey, which we would love to have you complete. This feedback will help us to improve future events and webinars. And that is everything. So thank you again for joining us here, and please enjoy the rest of your day.